Okay, so we are on time. So welcome to everybody. My name is Philippe Charon. I'm working in Paris at Pitié-Salpêtrière Hospital. And I am pleased to moderate the European Reference Network GUARD-Heart. So today we will speak about innovative therapy in hypertrophic cardiomyopathy. And indeed, there was a major progress in the knowledge of the pathophysiology and in the therapeutics of this disease. So we will discuss especially about common sarcomeric HCM. And we have two great experts, Pablo Garcia-Pavia and Michel Michels. So we will start quite rapidly now, and I remind you that you can put your questions through the chat, so do not hesitate to put your questions. So Pablo, you are able to start. So Dr. Pablo Garcia-Pavia from Madrid, Spain, will start with the first talk about the pharmacological treatment of HCM. Pablo.
Thank you very much, Philippe. It's my pleasure to be here today and talk with Michel about optimal pharmacological therapies for HCM. I'm going to talk first about, what we use in those patients who have symptoms regarding point of view of drugs. These are my conflicts of interest. When we look into the HCM patients that we take care of in the clinic, we see that there are several prognostic profiles. There are some patients that have a benign clinical course with normal longevity, but there is also a group of patients who have problems. And obviously this includes sudden cardiac death, heart failure, and thromboembolic complications with atrial fibrillation. So when we have a patient in our clinic, we always have to take care about 4 dimensions. One is the familial dimension with genetics and family screening. The other is about sudden cardiac death risk and what is the risk of ventricular arrhythmias, in my patient. And then we have 2 more, which is the cardioembolic complications and the heart failure symptoms. It is these last 2, the ones that are amenable or in which we use pharmacological therapies. So for the first one, cardioembolic complications, we know that atrial fibrillation is extremely common in patients with hypertrophic cardiomyopathy. You can see here the data from a meta-analysis showing that above 20% of patients with hypertrophic cardiomyopathy do have concomitant atrial fibrillation. But that's not the most important thing. The most important thing is that AF entitles embolic complications. And the prevalence of thromboembolic complications in this population is certainly high. You can see here that obviously these are referral centers, but above the history of the patients with hypertrophic cardiomyopathy, you can see that 1 in 4 will have an embolic event. In fact, the incidence of thromboembolic complications per year is around 3.75%, which will be around a CHAS basket score of 2 or more. So certainly, this is a disease that is linked with a high embolic risk. And therefore, this is one of the major complications that we can prevent in our patients. But it's important to highlight that CHAS basket score is not useful in this population because it does not capture well the nature of the risk in this population. Most HCM patients are below 65 years old, and there is the risk that if we use CHAS-BAS, we will consider that they are a lower risk and we will not anticoagulate them. We should anticoagulate every single patient with HCM and concomitant atrial fibrillation. In fact, if we want to select better which patients are going to have problems, rather than checking the chest basket score, it would be better to check what is the left atrial size, because this size and larger left atria have been associated with thromboembolic complications in this population. And in fact, we see that taking into consideration the left atrial diameter, above 45-50 millimeters, at that point, the risk of thromboembolism exponentially grows. So it is not uncommon in the guidelines, the 2014 guidelines, it was really made a recommendation to screen more intensively for atrial fibrillation in those who have larger atria. Regarding anticoagulation, obviously there aren't randomized clinical trials in patients with atrial fibrillation and HCM in order to see if oral anticoagulants was associated with less incidence of stroke. But there are some retrospective studies, as the ones that you see on screen, that have provided some interesting data on this topic. And you can see that those who were anticoagulated had lower rate of embolic events than those who were not on anticoagulation. So certainly, this is an important message from this presentation. Every single patient on atrial fibrillation with HCM should receive anticoagulation. With which agent? Well, we have two types of agents, vitamin K antagonist and also direct oral anticoagulants. There is no trial comparing both in this specific group of hypertrophic cardiomyopathy patients, but there are a couple of retrospective studies who have examined this, and there were no difference in efficacy in these studies, but those who received direct oral anticoagulants had more satisfaction, had higher satisfaction, and obviously this implies a better compliance for the patients. So this is something important. So nowadays, for example, in my clinic, we tend to offer always direct oral anticoagulants to these patients rather than vitamin K antagonist. If we move into heart failure in patients with hypertrophic cardiomyopathy can arise from different modalities. And obviously, we have non-obstructive HCM and also obstructive HCM. For non-obstructive HCM, the cornerstone of pharmacological therapies in this population is diuretics, coupled with rhythm control agents and rate control agents if the patient develops atrial fibrillation. But it's interesting how a new type of drug, SGLT2 inhibitors, is approaching this area, this space. And here you can see the data from a small study from India, 48 patients who received either SGLT2 inhibitors or they were not treated with SGLT2 inhibitors, and they were followed for 6 months. So you can see here that those who received the SGLT2 inhibitors had a better echocardiographic profile after 6 months, with an improvement in NYHA class and also on NT-proBNP and 6-minute walking test. So this really is emerging data that support somehow considering using this drug in patients with non-obstructive HCM. Interestingly, this very recent study has been published in cardiovascular research, and it shows that engineered heart tissue with mutations in MYH7 and troponin T treated with SGLT2 inhibitors showed enhanced relaxation. And actually, they were able to test which of these agents provided better relaxation. And it was shown that canagliflozin had a more intense effect on enhancing cardiac relaxation. So there is in vitro data supporting the use of these drugs in this type of patients. In fact, there are plans of launching a clinical trial on this specific population of patients treated with SGLT2 inhibitors. It's a difficult war for Spaniards, at least. What happens with obstructive HCM? Well, we have nowadays 4 different types of drugs: beta blockers, verapamil, diltiazem, so calcium channel blockers, and disopyramide and cardiac myosin inhibitors. The sequence of use of these drugs is found in the recently published guidelines for cardiomyopathies of the European Society of Cardiology. We start usually with beta blockers. If the patient remains symptomatic or is intolerant to beta blockers, we add non-dihydropyridine calcium channel blockers. And if the patient remains symptomatic, then we can choose between disopyramide or mavacamten, which is the only cardiac myosin inhibitor currently available. Interestingly, although beta blockers are the cornerstone and the initial first-line standard of care drug in this disease, there is only one study, control study, that has assessed the effect of a beta blocker in obstructive HCM. And this is the TEMPO study you see here on the screen, where 29 Danish patients were treated with metoprolol or with placebo during 14 days, and then they were switched to the opposite treatment arm. And in this study, it was shown that the treatment of metoprolol was associated with a decrease in gradients, with an improvement in shortness of breath and angina, but interestingly, no changes in peak VO2 and no changes in PCP wedge pressure, while stroke volume did improve a little bit compared to placebo in these patients during exercise. So certainly a very interesting finding supporting the beneficial effects about reduction of gradient and improvement of symptoms in this population. With regarding verapamil, even the data are poorer than with beta blockers. And here you can see one of the little number of papers which have published data on the efficacy of verapamil in this population. And this is a very, very old study published in JACC with 16 patients receiving verapamil. Interestingly, only 8 patients had a gradient above 30 millimeters of mercury, and only 2 of them had a gradient above 50 millimeters of mercury, which will be the thresholds now they use to consider that somebody has a significant obstruction, hemodynamically significant obstruction. Disopyramide is a great drug that we have been using for a long time, but with a very nasty profile of side effects. It does produce QT prolongation, but what is really painful for the patients is its anticholinergic side effects. And I don't know in your countries, but at least in Spain, there is periodic distribution shortage that really limits the prescription of this drug. And then the new kids on the block, which are the CMIs, and I will not go in detail on them because Michelle is going to discuss them further. but we know from the Explorer trial that was published in 2020 at Lancet that these agents are highly effective in decreasing or left ventricular outflow tract gradient with the side effect of decreasing a little bit the ejection fraction. And that's it. So in conclusion, we have pharmacological therapies in HCM to prevent thromboembolic complications and treat heart failure symptoms. Diuretics and rate-limiting medications are used in patients with non-obstructive HCM, and we have a wide medical armamentarium for obstructive HCM that probably will incorporate more alternatives in upcoming years. Thank you very much for your attention.
Thank you, Pablo, for this excellent talk. There is one question about patients with factor V laden variant could be more prone to embolic risk. So should we consider differently these patients? What do you think?
Well, I think that assessing the risk of a stroke in a patient always requires assessing the patient in global. So depending what are the characteristics of the patient, concomitant findings are really important for considering if a patient should be initiated on anticoagulations or not. So if a patient does have obstruction with some problem with factor V or whatever, I think it's something to consider. And sometimes I will be maybe more aggressive in treating the obstruction in that patient to prevent MR and prevent dilatation of the left atria that probably will prone that patient into AF. So maybe there are other ways of trying to handle those patients.
And more generally regarding atrial fibrillation prevention or anticoagulation, do you have some patients you would like to treat with anticoagulation before the occurrence of atrial fibrillation? You said left atrium is a predictor. So we instances, yes.
Yeah, we anticoagulate patients in a routine basis. I mean, this is not based on guidelines. This is not based in science, I will say. Well, or it's not entirely based in science, which is we use a threshold of 50 millimeters of diameter of the left atrial. And if the patient is above that limit and doesn't have any contraindication for anticoagulation, we tend to start them on direct anticoagulation because we think that the chances of that patient of developing atrial fibrillation are super high. And we don't want problems to come afterwards. So yeah, if the patient has no contraindication and is young and we don't think is going to have problems from anticoagulants, we will recommend those patients to go into this drug.
From my side, I should say I am still reluctant to start before atrial fibrillation, but I think you are right. This is an area we should work on probably, yes. And what do you think about interventional ablation procedures? Because once atrial fibrillation is there, of course, we would like to avoid any recurrence.
Yeah.
But
I think it's really, I think it's really important to consider those kind of procedures, but those procedures should be considered in the appropriate patients. So if the patient has severe MR or important MR linked with an obstruction, I think it's somehow pointless to do pulmonary vein ablation because we are not correcting the underlying mechanism by which the patient is developing this problem. The same happens with obesity or with sleep apnea. or uncontrolled hypertension. So we need to go into the underlying factors that are causing the atrial fibrillation. Otherwise, we know that the success rate of pulmonary vein ablation in this population is much lower. So we tend to offer that to patients when they are in an early stage, but if they have already been on atrial fibrillation for more than 1 year or so, I think the chances of success are very, very small.
Thank you. And one question from the chat. What do you think about gliflozin in obstructive form of HCM?
I think diuretics in obstructive HCM is a complex scenario because you don't want to decrease circulating volume in these patients, because if you decrease the volume, then the obstruction is going to increase. So I'm not entirely in favor of using them in patients with obstruction. I mean, it can be considered in a day-by-day basis, but I'm not sure that that is the appropriate thing to do.
And we have now additional opportunities and classes of drugs. So this is a perfect link for the second talk. So thank you, Pablo. And at the end, it will be also a possibility to ask additional questions. So now I am pleased to propose to Michels to speak now. She is from Rotterdam, Netherlands, and she will speak about the new therapies in this disease. Thank you, Michelle.
Yeah, thank you very much for the introduction. So the topic of my talk today is evidence-based novel therapies in hypertrophic cardiomyopathy. I'm based in Rotterdam in the Netherlands, and my main field of interest is hypertrophic cardiomyopathy. So these are my disclosures. Well, I participate a lot in all these new drugs, so you can see all the firms over here. So I'm going to start to talk about the management of hypertrophic cardiomyopathy with obstruction. And in this slide, what you do see are two flowcharts, one from the 2023 European guidelines for the management of cardiomyopathies, including the management of hypertrophic cardiomyopathies. And what you can see here, as Pablo already showed, that we normally will start in patients with symptoms and a resting or provocable left ventricular outflow tract obstruction equal or exceeding 50 millimeters of mercury. And if patients are symptomatic, we normally will start with beta blockers. And if patients remain symptomatic or are intolerant to beta blockers, then we add or change to a calcium channel blocker, either verapamil or diltiazem. And then if patients remain symptomatic, we can switch to disopyramide, but this has some disadvantages. And also in the Netherlands, as Pablo just mentioned, we have shortage, so we just can't get any disopyramide. Or we switch to a novel drug called mavacamten, and this is a cardiomyosin inhibitor. And if all these medications fail, we can still move forward to septal reduction therapy. And then very recently in May, the American guidelines came available, management of hypertrophic cardiomyopathy. And what you can see here, so this is our patients again with obstructive hypertrophic cardiomyopathy, symptomatic patient. I think it's still very important to avoid vasodilatators and high-dose diuretics. I'm also not sure about SGLT2 inhibitors, but I would usually not prescribe them to patients with hypertrophic obstructive cardiomyopathy because they do have a diuretic effect. So if patients are still symptomatic, also the American guidelines advise to start with beta blockade or calcium channel blockers. If symptoms persist, there are 3 choices to be made. So I think there's a stepwise approach in the European guidelines where it's more like they're a little bit more equal. Either start with a myosin inhibitor, and they changed already from mavacamten to just a class myosin inhibitor, disopyramide, or septal reduction therapy. So Mavacam 10 is a first-in-class myosin inhibitor, and it's based actually on the pathophysiology of patients with hypertrophic cardiomyopathy, because what we do know, so in a normal heart, we have normal contraction, normal relaxation, and in patients with hypertrophic cardiomyopathy, we have excessive contraction, and we also have impaired relaxation. This is caused by an excessive number of engaged myosin-acting cross bridges. These are based in the sarcomere, which is the smallest contractile unit in the myocardium. And Mavacam 10 is a selective cardiac myosin inhibitor, and it reduces the number of force-generating myosin-acting cross bridges. So this means it reduces systolic function, so a little bit of reducement of ejection fraction, and it's probably also better for diastolic, for relaxation of the heart. And evidence from human HCM hearts showed that if you add Mavacam 10 to a HCM heart, you can see that the percentage of the myosin heads that are in off state, so that are relaxed, not engaged to the actin, returns to normal. And this drug, so this is all based on a gain of function that we know from myosin heavy chain mutation carriers. So the myosin heads from off state in on state. There are preclinical data from mouse, but also in dogs, where these drugs are shown to be, so they reduce the contractility, increased compliance, improved energetics, decreased left ventricular hypertrophy, disarray, and myocardial fibrosis. And then they moved on from this preclinical data to clinical studies, and first of all started in patients with hypercontractile left ventricular ejection fraction and left ventricular outflow tract obstruction in symptoms. So this led to both the 2 phase 3 trials that are finished, the Explorer and the Valor, and I will speak about them in the next slide. And as you probably are aware, these drugs are currently being tested also in a phase 3, the Odyssey HCM trial. So Mavacam 10 in HCM patients with obstruction has first been tested in a phase 2 trial. There was a Pioneer HCM trial. It was a trial that was done in the US. It was open label, non-randomized, only 21 patients, and it was mainly about safety. So this was a very short trial, patients in NIA class 2 or 3, and it was dose finding as well. So you see different doses, and primary endpoint was change in post-exercise left ventricular outflow tract gradient. And the study was positive, and then afterwards the Explorer trial was designed. The Explorer trial has been published in 2020 in the Lancet, first author Jacopo Olivotto from Italy, double-blind randomized trial, including 251 patients during 30 weeks, NIA class 2 and 3, and the primary endpoint was based on exercise capacity, symptom burden. So this is a combined endpoint based on VO2 max and NIA class. And there were secondary outcomes, so reduction in left ventricular outflow tract gradient, improved exercise capacity, decrease in NIA class, decrease in biomarkers, and improved diastolic function. This study also was conducted in the Netherlands, but also in Europe. And then another study, the Valor HCM, was done in the US. This was also a double-blind randomized trial, and these were patients with hypertrophic obstructive cardiomyopathy that were eligible for septal reduction therapy. So they were more symptomatic, NIA class 3, and they were treated for 16 weeks, and the primary endpoint was continued eligibility for SRT, and it was significantly decreased in the patients that were treated with Mavacam 10. So these 2 trials led to the approval of Mavacam 10 by the FDA and by the EMA last summer. Are these drugs too good to be true, or is MAVA too good to be true? Well, in the trial, so these are data from the Explorer trial, the treatment emergent adverse events and serious adverse events were very little and were actually equal in both the Mavacam 10 and the placebo group. There are, however, some points of attention. I think the most important one is that mavacamten is metabolized over a cytochrome P450. And I think you all know that many of our drugs use this cytochrome. So this also means that there are significant drug-drug interactions. And in Europe, as the EMA prescribed, that we should genotype CYP2C19. They are contraindicated in pregnancy, and they need very close echocardiographic monitoring. And mavacamten has a pretty long half-life of 6 to 9 days, and this can go up to 23 days in poor metabolizers. And this led to the summary of product characteristics. This was published last summer by the EMA. And this is actually how we should use mavacamten in everyday clinical practice. So in patients that are non-poor metabolizers, the starting dose is 5 milligrams once daily, and we can only initiate this in patients that have an ejection fraction equal or above 55%. And this is because we know that the ejection fraction can come down. And then at 4 weeks, we see our patient back. We perform a new echo. And if your Valsalva LVOT gradient came down below 20, then you should decrease your dose. We see them back again at 8 weeks. And then again at 12 weeks. And at 12 weeks is actually the first time where you can increase the dose. And after 12 weeks, you see your patients back every 12 weeks. So this is putting a burden, I think, on our echo capacity. But it's something I think we just have to get used to. And hopefully, if more real-world data came out, then hopefully the controls shouldn't be that strict anymore. So the drug has been available in the US for quite some times now, and these are the real-world data that has been published in this year by the group of the Cleveland Clinic, describing their first 150 patients. They're a little bit older than the patients in the trials, also a little bit more females. The end dose of mavacamten is 5 milligrams, so which is actually the starting dose in the US, and they don't have to genotype their CYP2C19. And in 16% of the patients, they had to adjust the treatment for drug-drug interactions, and they need to interrupt mavacamten in 3 patients because the ejection fraction dropped below 50%. So what you can see in the panel below, this is the ejection fraction. You see it coming down. Also in the US, all patients should have an ejection fraction above 55 before the start of mavacamten, but you see it coming down in almost all patients. But you also see a very good decline in left ventricular peak gradient. So this is with Valsalva, and this is at rest. So a very good therapeutic approach or effect which is already accomplished at 4 weeks at your first echo. And you can also see that if you go from baseline to 12 weeks, that there's an improvement in NIA class. So no patients on baseline in NIA class 1, and a third of the patients is in NIA class 1 at 12 weeks. So you can quite clearly see that it's a very effective drug. And these are data from Philadelphia, published recently in JACC Heart Failure, describing their almost 100 first patients treated with mavacamten. Again, a little bit older than the patients in the trial, more females, and they had to temporarily interrupt the treatment because of a drop in ejection fraction in 2 of their patients. These are the effects on the left ventricular outflow tract gradient. In red is the gradient at Valsalva, and this is in blue, the resting gradient. And here you can also see that at 36 weeks, so a little bit longer here, that many of the patients, 3/4, did show an improvement at least 1 NIA class. Also in this trial, most patients on 5 milligrams, although they also had some reduction in therapy and some were increased to 10. And what they also showed in this trial that they were able to stop the background therapy, so stop the beta blockade or the calcium channel blocker in a part of these patients. So I think the real world data are resembling the data in the trial, and I think that's very reassuring. And this is a patient from our own clinic. So this is a female of 68-year-old with a clear phenotype of hypertrophic obstructive cardiomyopathy. At baseline, you can clearly see the asymmetrical thickening of the myocard. You can see the systolic anterior motion of the mitral valve, and in the panel below, you can clearly see the left ventricular outflow tract peak gradient that is over 100 millimeters of mercury. This was with background therapy with beta blockade, and she was in sinus rhythm at rest 57. So I think she was quite properly beta blockade, but still was very obstructive. We put her on 5 milligrams of Mavacam 10, and this is the echo. Oh, excuse me. I just go back one slide. Just try to make this move. So this is the echo at 4 weeks, and you can see there's a complete abolishment of the left ventricular outflow tract gradient, and the patient did improve from neoclass 3 to neoclass 1 just in 1 week. And she's now on therapy for, I think, 5 months, and she's still doing fine. Avicam 10 is a next-in-class cardiomyosin inhibitor that has been developed a little bit based on Mavacam 10 and just an improvement of Mavacam 10. So the half-life is shorter, which means that more rapidly a steady state can be achieved, allowing also rapid dose adjustment, but also rapid reversibility. So if you end up in trouble, if you stop the drug, the half-life is just shorter. There's a shallow dose response relationship, and there are minimal drug-drug interactions because there's no clinical significant CYP inhibition or induction. So I think this is an improvement. And the first trial of Avicam 10 in hypertrophic obstructive cardiomyopathy is called the Sequoia. And this has been presented by Martin Maron in May in Lisbon and published in New England Journal of Medicine. This was the study design. So again, patients with hypertrophic obstructive cardiomyopathy, symptomatic left ventricular outflow tract gradient at rest equal or exceeding 30 millimeters of mercury, and at Valsalva equal or exceeding 50 millimeters of mercury, and also a predicted peak VO2 below 90% for age and sex. Patients were randomized 1-to-1 Avicam 10 or placebo, and I think you can see here. So in Mavacam 10, those adjustments are at week 4, week 8, and week 12. With Avicam 10, it's week 2, week 4, and week 6, and you can adjust your the dose. And these are the primary endpoints. So this is the mean peak VO2, and you see a significant increase, 1.7 millimeters per kilogram per minute. So this was really significant. And also the secondary endpoints were all significant. So you can see here the results on the peak resting left ventricular outflow tract gradient, really showing nicely that the gradient is reduced in the Avicam 10 group and remains stable in the placebo group. So this study was a study with a duration of 24 weeks. Afterwards, there was a 4 weeks washout period. And during this washout period, you see that the left ventricular outflow tract obstruction actually comes back. These are the gradients after Valsalva. These are also again showing an improvement in NIA class in the Avicam 10 group. And I think what's also really important that there was a significant improvement in KCCQ. And I think if you take into account also the washout period, you can see that the higher KCCQ in the patients treated with Avicam 10 actually ends up lower than the placebo group. So this trial was very positive. also for subgroup analysis. So there was no difference between sexes, nor between age, body mass index, NIA functional class, left ventricular outflow tract ejection fraction, NT-proBNP. It didn't matter if you put your patient on a cycle ergometer or on a treadmill. Beta blocker use, no difference. KCQ, no difference. And I think, and this has also already been shown in the Explorer trial, there's also no difference in the genetic background of the patients. And this, at the beginning, came as, I think, a little bit of a surprise, because the drugs were actually developed based on myosin heavy chain mutation carriers, but genetic status is not included in the inclusion criteria. And you can see also in the results from the Sequoia trial, as in the results of the Explorer trial, that if a patient has a pathogenic or likely pathogenic DNA variant, it doesn't matter for the results of the trial. So that is promising, I think. Pablo already mentioned, so we do have patients with obstructive phenotype, but also those with a non-obstructive phenotype. And Mavacamten has been tested in a phase 2 trial, the Maverick trial, that has been published in 2020. And what they did show in a small proportion of patients, that if you treat patients with non-obstructive hypertrophic cardiomyopathy, that you see a clear improvement, at least in biomarkers. And this study has been the base, and that it was safe as well. And this study has been the base of the ongoing Odyssey trial. And I think we expect the results the first half of next year. Aficamten has also been tested in non-obstructive HCM. So the phase 2 trial of Aficamten is called the Redwood HCM trial. There are 4 different cohorts, and the 4th cohort was a non-obstructive cohort. So this was a patient with symptomatic non-obstructive hypertrophic cardiomyopathy. So resting unprovoked left ventricular outflow tract gradient below 30 meters of mercury. New York Heart Association class 2 or 3, left ventricular ejection fraction above 60, and these patients should also have an increased NT-proBNP. And this study was positive, so it showed improvement in KCCQ. It showed a decrease of biomarkers, especially NT-proBNP. It showed improvement in NIA class in the patient, and this is a score that has been developed to quantify chest pain. And you see also that patients that are treated with Aficamten have less chest pain. And this study has been the base for the Acacia study that is including patients in the US. I don't know about the other European countries, but we will start I think just after the summer, we will start with including patients in the Acacia trial. So this is Aficamten in patients without obstruction. Do we only have cardiomyosin inhibitors in hypertrophic cardiomyopathy that are tested? No. During the ACC, the Improve HCM study was presented by Marty Marin. This is a study done with ninirafustat, and this is a drug that is known to create a metabolic shift, so from fatty acids to glucose. So it enhances cardioenergetics, and it's called a cardiac mitotrope. They included patients with non-obstructive hypertrophic cardiomyopathy, again, left ventricular outflow tract gradient below 30, ejection fraction below 50, so a little bit lower than those patients in cardiomyosin inhibitor trials, because we're not afraid of a reduction in left ventricular ejection fraction with this drug, and a peak VO2 below 80. And what they did find in this phase 2 trial was that there was improved ventilatory efficiency and also improvement in KCCQ. So the patients actually felt better, and they're currently preparing a phase 3 trial with this drug. So I think this is also coming towards it, at least in research. and can be promising for those patients that are non-obstructive and have a little bit of a reduced ejection fraction and can't use cardio CMIs. And then I think a last word about gene therapy and hypertrophic cardiomyopathy. So what we do know from patients with myosin binding protein C3 related hypertrophic cardiomyopathy, we know that there's haploinsufficiency, so there's less normal myosin binding protein C3 protein, and the goal of gene therapy is actually repairing this gene defect and well, restoring the normal amount of myosin binding protein C3. And currently, two phase 1 trials are conducted in the US by Tenaya and BioMarine, focusing on gene therapy and hypertrophic cardiomyopathy. So they use an adenovirus vector to introduce working myosin binding protein C3 in the patients. And well, hopefully what we are going to see is that the working myosin binding protein C3 gene will cause normal amounts of myosin binding protein C3 protein production and restore function and heart muscle cells. So with that being said, I think well, the future is pretty bright for patients with hypertrophic cardiomyopathy because we're really entering the era of precision medicine, and a lot of studies are conducted, and we are happy that we can be part, I think, of this journey. And I think for cardiomyosin inhibitors, they already made it into the guidelines, both the European and the ESC guidelines with well, high level of evidence, and hopefully we will see the same happening in patients with non-obstructive hypertrophic cardiomyopathy. Metabolic therapies and gene therapies, I think they're, well, that's a little bit further away, but also promising, I think, for our patients. And this is my last slide. I'd like to thank you for your attention and happy to take any questions.
Thank you very much, Michelle. Excellent talk, and it's very impressive, very amazing to see the number of trials underway in this disease. Really, there was a major change for some years. So perhaps the first questions about cardiac myosin inhibitors. So you said the risk of systolic dysfunction, especially with MAVA content, but also with AFI content, is in fact relatively low, and there are data from the real world that are also reassuring about this risk. So probably 1 or 2% may have this systolic dysfunction. So we should be careful, but probably the risk is quite low indeed.
Yeah, and I think so. If you read the papers and talk to the authors of the real world data in the US, I think there are, well, some signs that patients that end up in rapid atrial fibrillation, that they tend to have a reduction in the ejection fraction. So I think that's important, that if the patient is in AFib, that you see them relatively quickly and also treat it. Patients with so patients in both trials, patients should be in sinus rhythm or at least in controlled atrial fibrillation. So I don't think we have that much of experience in patients with uncontrolled fast AFib. So I think that's a patient cohort that we should pay attention to. And there also have been some anecdotal description of patients that are septic and then to end up in ICU. So I think these are specific patient group to focus on. So this far in our own experience, we didn't see any significant drop in ejection fraction yet. I don't know, Philippe, you also have experience, and Pablo also, if you did see that.
Yes, very few cases, and usually after stopping the drug, we see the good evolution of the systolic dysfunctions who recover. So it's also a good point. Yes. We have a question about the strategy for obstructive forms. In which cases do you think we should promote mavacamten or disopyramide or septal ablation? We show slide about the US guidelines that it is now at the same level to discuss septal ablation or pharmacologic drugs. So what do you think in your practice about the choices in these patients?
Yeah, I think for me it's quite difficult to say something about disopyramide because it's really been a problem to get disopyramide. And I don't think we ever going to see a head-to-head trial of comparing cardiomyosin inhibitors against disopyramide. I think so. What we currently do is that we discuss all options with patients. So if they fail therapy with beta blockade and calcium channel blockers, I think my own preference is to put them on a cardiomyosin inhibitor. But I think we have to discuss with the patient what they prefer, and we did have patients that preferred just to be operated, just to get like over it and don't have all these controls and use medication. Cardiomyosin inhibitors, I think you should not treat young females that still have well, a childbearing wish. You should not treat them with cardiomyosin inhibitors because you can't proceed with that during pregnancy. So then you should take the patient off and you'll have a patient again that is symptomatic with hypertrophic obstructive cardiomyopathy. So in young female patients that they still have a pregnancy wish, I think we tend to move to septal reduction therapy. And I think what's currently lacking is that we don't know from the Explorer trial and also from the Sequoia trial which subset of patients are the non-responders. So are there specific patients with anatomical features like really long anterior mitral valve leaflets or abnormally papillary muscles? Do they all respond that well to cardiomyosin inhibitors? I think we don't know that yet. But yeah, I don't know, Pablo, what you think about that.
Pablo, what is your strategy?
I did not hear well the last sentence. We missed my strategy.
Well, well, it's about so how you decide between cardiomyosin inhibitors or septal reduction therapy for a specific patient. And I just said that we don't. I think we currently don't have enough information about the non-responders in both Explorer and Sequoia, whether or not there are specific anatomical features or.
Yeah, I mean, in Spain nowadays, we don't have access to CMIs yet, only in trials. So that simplifies the decision because that's not an alternative only for selected patients who are not good candidates for myectomy. We can request compassionate use of the drug. I think we will need to certainly evaluate very carefully the anatomic structure of the valve, and particularly where are the papillary muscles implanted. And I think taking into decision that, I think is going to play a major role into where if the patient might respond or not to cardiac myosin inhibitors. Given said that, I think it looks to me that a majority of patients will go into cardiac myosin inhibitors first, because you are never 100% sure if the patient is going to improve or not. So I think the common structure that we're going to follow once they become available will be to try them, patients on them, except if the patient is doing very poorly and you need, for whatever reason, to improve them very quickly. Because if you don't have the benefit of time of up titrating the drug, probably we have had that experience with some patients that because of personal preference, they want to get rid of the obstruction as soon as possible, and they don't want to go through the process of up titrating the drug with this 3 months interval that the European legislation requires.
I agree with you that in the majority of patients, pharmacological treatment first, and optimizing this pharmacological treatment with myosin inhibitors is probably a good solution. But this is always a discussion, a case-by-case discussion with the patient about the options. And the Valor study is about this efficiency to reduce the indications possibly for septal ablation. We have a question on the chat about pharmacogenetic interactions and the need or not to genotype for CYP3 CD19 genotype. So can you remind us how this is a requirement, in fact, in Europe, at least for starting and doing the titration of the dose of mavacamten. So I'm afraid we will still need to genotype these patients for mavacamten at least. For aficamten, possibly could be different, or what do you think?
Yeah, so I think so. So the EMA decided to, well, that we all should genotype to C19 for mavacamten. So not for aficamten. Well, that has not been decided yet, but it doesn't. It's not being metabolized over cytochrome P4 and 50. And at least I think so. Currently, I think there are negotiations everywhere. So we just have the drug in the Netherlands starting from the 1st of June. It's been reimbursed, but also in the Netherlands, it's just, well, we have to genotype the patients. So the FDA didn't prescribe that, but that's also to do with that's not that normal to, so it's just not available in clinical care in the US. On a routine basis. It is in the Netherlands, and I see that the question comes from Lithuania. Yeah, I don't know about your specific country specific, because maybe if it's very difficult, then, well, I think that the national government can still decide on something else, but then probably, I know the discussion was about, so if you don't genotype your patient, then the starting dose is 2.5. So with an unknown CYP2C19 genotype, then you can start with 2.5, but then you can only increase your dose to 5, which is about half of, a little bit more than half of the patient ends up with 5 milligrams. So then it's going to take some time, because it's like, 4, 8, 12, and then 12 weeks is the first time that you can actually increase your dose. So if feasible, I think it's good to, it costs about 500 euros. You should send it to the Netherlands.
So this is
really expensive. You should talk to BMS.
You should talk to BMS, because probably they're going to provide you free genotyping for this in order to promote prescription.
Yeah.
So
I know they do that in Italy. So in Italy, the genotyping is covered by BMS.
In Spain as well.
Oh, really?
Yeah, there is a program. Well, to those who requested, BMS sponsorizes a program of genotyping. If the hospital doesn't have that available, then there is the option to do it through that system.
Oh. Interesting to know. In France, no support.
In the Netherlands, also not.
So thank you very much for this very interesting session. So I think that all this information will be useful to the attendees. So thank you very much, Pablo and Michel, for this session.